RV is a 47-year-old female with a past medical history of generalized anxiety disorder and hyperlipidemia. She presented to the ER 2 weeks ago complaining of ongoing night sweats, fever, chills, fatigue, nausea, and abdominal pain. She also reported unintentional weight loss over the past several months. It was at this time that she was diagnosed with HIV/AIDS and MAC. She was started on MAC therapy in the hospital and will continue until her CD4 count is greater than 200, and she has been on ART therapy for 3 months. Her hyperlipidemia is currently under control, but with initiation of ART, we will need to adjust the current drug therapy. The patient states her generalized anxiety disorder is currently under control, but we plan to refer to psych for evaluation given recent diagnosis. Her past medical history includes generalized anxiety disorder for 5 years and hyperlipidemia for 3 years. She presents very thin and fatigued with an enlarged left lymph node, otherwise unremarkable. Her social history includes alcohol use of 1 to 2 beers a week socially and cocaine intranasally on occasion. She is single with a history of 35 male sexual partners over the last 27 years. She admits to oral and vaginal sex, which is occasionally unprotected, and she has had 3 partners in the last year. Her allergies include a rash to penicillin. Her current medications are simvastatin 80 milligrams at bedtime, St. John's wort 300 milligrams 3 times daily, lorazepam 2 milligrams at bedtime as needed, azithromycin 500 milligrams daily, ethambutol 800 milligrams daily, and levofloxacin 500 milligrams daily. She was diagnosed with HIV/AIDS 2 weeks ago with HIV-1 genotype. Her viral load upon discharge was 120,000 copies per milliliter with 5% CD4. ART therapy has not yet been initiated due to her MAC infection, low CD4, and risk of virus. She was diagnosed with MAC 2 weeks ago. Her white blood cell count was 1.55 cubic millimeters upon discharge, which is low due to her immunodeficiency. Her pertinent diagnostics include a negative silver stain, a positive Mycobacterium PCR for M. avium complex, and negative for M. tuberculosis. Additionally, her chest x-ray showed nodular cavities, and a chest CT showed multifocal bronchiectasis and multiple small nodules. For the patient's hyperlipidemia, she is currently on simvastatin 80 milligrams. Due to initiation of antiretroviral therapy, her statin levels will increase with therapy. We will discontinue simvastatin 80 and initiate atorvastatin 10 and titrate to an effective dose. The patient states her generalized anxiety disorder is well controlled with lorazepam. She is cooperative, awake, alert, and oriented ×3 and is in no apparent distress.
For the patient goals for her HIV/AIDS therapy, we want to restore and preserve her immunological function by having her CD4 count as high as possible, and for her HIV viral load to be undetectable. We also want to prevent the transmission of her HIV, reduce associated morbidity, and prolong her duration of survival, as well as improve her quality of life. The goal for her MAC is to resolve and cure the infection. We want to discontinue MAC therapy upon completion of chronic maintenance therapy with no signs and symptoms of MAC disease and a sustained CD4 count of at least 6 months with greater than 100 cells per cubic millimeter. Our goal for her hyperlipidemia is to lower her ASCVD risk, to reduce the 10-year mortality, and the goal for her generalized anxiety disorder is to keep it well under control. Moving on to the plan for HIV and AIDS, we want to discontinue her St. John's wort 300 milligrams and initiate the following therapy, which will be taken 1 tablet by mouth daily: tenofovir, alafenamide 25 milligrams combined with emtricitabine 200 milligrams, darunavir 800 milligrams, ritonavir 100 milligrams. Then we want to initiate an opportunistic infection prophylaxis treatment of Bactrim DS. For MAC, we want to continue the current MAC therapy. And for generalized anxiety disorder, we want to continue her current therapy. Alongside, to maximize the benefits of generalized anxiety disorder, we refer the patient to a psychiatrist and also recommend she seek out counseling or a support group for a new diagnosis of HIV/AIDS. For hyperlipidemia, we want to discontinue her simvastatin 80 milligrams and initiate atorvastatin 10 milligrams, 1 tablet by mouth every night. We will titrate it up to 40 milligrams daily. Our follow-up plan, we will follow up with RV in 1 week to assess her CD4 count and viral load, as well as her signs and symptoms of MAC and her